Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case about a 27-year-old female who was a postpartum who came to our ER with complaints of multiple episodes of vomiting since the past 3 days associated with generalized tiredness.
Okay.
So, sir, on initial assessment, the patient was conscious oriented and was able to complete one full sentence. In the airway was patent and there was no pooling of secretions. Coming to the breathing, but the respiratory rate was 18 per minute and air entry was bilaterally equal. Her saturation was maintained in room air 99%. In the circulation, all peripheral pulses were palpable and her pulse rate was 115 per minute with a BP of 220/130. Sir,
BP is high.
Her BP was high, sir. And she came with complaints of
what is the pregnancy duration?
Sir, postpartum, sir.
Postpartum.
Postpartum. So, BP was high and we went ahead with the primary survey. In the disability wise, GCS was full and the pupil was bilaterally equally reactive and temperature was afebrile. And went ahead and coming to the adjuncts, ECG was showing sinus tachycardia with heart rate of 114 and we took a VBG also. VBG was showing a pH of 7.48 with PCO2 of 35 and bicarb of 26. Potassium was 3.4 and her lactate was 1.5.
This is a young lady.
Postpartum
time. What are the important histories and investigation you will ask in a patient who is having hypertension like this? High BP is not usual for that age group. So what history leading questions you will ask the patient and what important investigation you will take from the emergency room?
History of hypertension in the past and history of hypertension during pregnancy.
So is it there?
She was a non-case of hypertension.
She is a non-case of hypertension. During pregnancy, BP was high?
BP was high.
Okay.
And history of any seizure. Then history of any decreased urine.
So hypertension in pregnancy can be classified into a pre-existing hypertension increasing during the pregnancy. During pregnancy time, without previous history, BP increases. Last one is preeclampsia, eclampsia, high BP, like that. That is the last stage only we come to know all these things. So these categories, patient had hypertension in the past. During pregnancy, it was slightly high. After postpartum, it is still high. When was the delivery?
Delivery was 1 week back, sir.
Okay.
1 week back.
Okay.
So, sorry, one month back.
So, it may not be directly related to pregnancy at all. Because 1 month back, pregnancy is over, delivery is completed, and now also BP is still high and it is very high.
And
what are the basic investigation you will ask from the emergency room in a postpartum lady with high BP?
Urine protein.
Urine protein is a routine test done in pregnancy period to know whether the eclampsia is there or not. Many patients who is having hypertension also, urine protein will be there. Rather than the young lady coming with hypertension.
Creatinine value.
Okay, one is important thing is creatinine.
Then USG can be done, USG renal artery Doppler.
USG and renal artery Doppler.
Then echo to rule out any.
Echo to see whether any chamber enlargement is there or not.
Then electrolytes.
Which electrolyte is the most important?
Sodium. Then
sodium
magnesium.
Is not that important in hypertensive patient. Sodium high. If you take high salt, BP can increase. That doesn't mean that your blood sodium will not increase. Will increase. So sodium is not that important in a patient who is having hypertension. Serum sodium is not that important. Oral, like taking salt, it should be controlled.
Magnesium.
Most important is potassium. Magnesium is important in eclampsia cases, but not in routine hypertensive patient. The young patient who is having high BP, when you told renal Doppler can be done. Okay, that is okay. Echo should be done. ECG should be done. Potassium is very important. Why potassium is important?
If there's any adrenal,
Adrenal gland enlargement, like Cone syndrome. What happens?
potassium will lead to
Potassium will
excreta.
Potassium will be low. So hypertension, low potassium, high urinary potassium. Okay. So potassium is the most important electrolyte in young hypertensive patients. Okay. Okay. Potassium is here 3.4.
3.4.
Slightly lower, but it is normal range. Okay.
Then shall we move on, sir? So coming to the secondary survey, she was a non-case.
What is the pH?
Sir, 7.48.
Alright, that towards alkalotic side.
Okay. Multiple episode of vomiting.
Okay.
So she was a non-case of hypertension with the SLE.
So that may be the reason for hypokalemia also. How do you prove that it is the reason for hypokalemia?
Urine potassium.
Urine potassium. If urine potassium is still high, when there is a hypokalemia, then the urinary loss is the reason for the hypokalemia.
Then she was non-case of SLE also.
Okay.
With the history of on examination bilateral grade 2 hypertensive retinopathy.
Okay.
And the history of HELP syndrome.
Okay.
With
During this pregnancy or last pregnancy?
during the last pregnancy.
Last pregnancy.
And with the complications during the pregnancy with the severe thrombotic microangiopathic changes, aka alveolar hemorrhage, and was done as LSES was done.
Okay. SLE is basically a skin disease. But when there is a skin disease, it can be associated with vasculitic changes also. It involves all the organs in our body, eyes, brain, kidney, lungs, heart, everything. The basic problem is vasculitis. Okay. Whereas in skin, it is a redness of the skin, face, redness, loss of hair, all these things. But when it becomes systemic problem, basically it is a vasculitic change occurring everywhere.
So she was on tablet Nicardia BD, Nicardia retard BD, and metoprolol XL25 OD. Then he was also on hydroxychloroquine, Azoran for
Nicardia, nifedipine and metoprolol for antihypertensive. Azathioprine and hydroxychloroquine is for SLE.
So she came to the ER with complaints of multiple episodes of vomiting since the past 3 days, associated with tiredness and facial edema.
Okay.
That was for last 1 day. And there was no history of any.
What neurological complication can occur due to severe vomiting, especially in pregnancy?
Seizure.
It can produce wernicke's encephalopathy. Okay. Thiamine deficiency, especially in pregnant ladies, hyperemesis gravidarum, or during postpartum period also they can develop this problem. So, but this patient is fully conscious.
And there was no history of any abdominal pain, loose stools, blurring of vision, headache.
Why abdominal pain is important in this patient? What are the differential diagnoses you think when there is this type of patient come with abdominal pain?
One is abdominal pain itself causing hypertension. Any normal cause for abdominal pain causing hypertension.
No, pain induced hypertension. So any pain, including post surgery, post LSCS or renal stones, that itself can increase the BP. Okay, one is that.
Then other than that, renal artery stenosis.
The SLE patient vasculitis is one of the important problems. The renal artery stenosis or renal artery obstruction is known. So that is another possibility. Okay.
And then there was no history of any blurring of vision, headache, no history of any dysuria, fever also. And there was no history of any decreased urine output. And so she was, this was the complaints mainly. And the history was same, and further evaluation led to she was only having the hypertensive changes with the multiple episode of vomiting.
Okay.
So initially she was not having any end organ damage from the initial evaluation. We sent for the routine investigation. Routine investigation was done.
You want to check the vision in this patient?
Vision.
Why?
And because of hypertension, which will cause hemorrhages,
One of the most important cause for visual loss like high BP,
papilledema,
posterior reversible,
encephalopathy,
press, posterior reversible.
encephalopathy.
Okay.
That was done, sir, and ophthalmic evaluation was also done. And during that time, there was no features of papilledema was seen. It was managed with routine hair medication she was taken, and we also give her a injection. Labetalol was given.
Okay. So you told about papilledema. Papilledema is there or not?
Papilledema was history of papilledema was there, but
not at present. Okay.
And labetalol injection was given.
Labetalol, what was the dose given?
5 mg IV.
Which all conditions you give labetalol as a first line therapy in hypertensive emergency? Which all condition you don't give labetalol as a first line therapy?
Labetalol can be given in hypertensive emergencies, then hypertension in pregnancy, then in aortic syndromes, hypertension labetalol can be given. Then
almost all types of hypertensive emergencies you can give labetalol. Even in pheochromocytoma, if you see pheochromocytoma, beta blockers cannot be given as a first line drug because most of the beta blockers like metoprolol, that has only got beta blocking activity. Alpha is not blocked, but if you block only beta blocking effect in pheochromocytoma, unopposed alpha activity will occur. That itself can create more symptoms. But labetalol has got an advantage that it has got both beta and alpha, but it is predominantly beta. Okay, so almost all conditions you can use labetalol. Whichever hypertensive emergency you take, you can use labetalol. Okay.
And after the initial dose itself, her BP came down to nearly from 220 came below 200.
Okay.
And for further reduction of BP, she was admitted.
Okay.
And our plan is to decrease the BP like 25% within the initial 1 day, then reduce the BP.
So why you don't? So this is one of the most important area. ER physician should be careful. Any hypertensive emergency, control of BP has to be very slowly over 24 hours unless until there is a dire emergency like bleed in the brain or severe seizures like that. We have to control fast. Otherwise, maximum 25% can be controlled within 24 hours. That is enough. Why we need to control like that? What is J-curve response?
So J-curve response is the condition where if we suddenly reduce the BP, the patient it will be shown like a J in the, if you plot the BP, so patient can have a high degree of mortality.
So when you rapidly reducing BP, all our internal organs like brain, kidney, heart, everything is set for that high BP for a long time. Suddenly you are dropping your BP by giving some drug or infusion or sublingual tablet. Suddenly when the BP drops down, all these internal organs suffer from ischemia, especially kidney, brain. Okay, that increases the mortality. That's why sudden reduction of BP is not advisable in any hypertensive emergency unless until there is a problem like a seizure induced by intracranial bleed or something like that. Okay. So that is J-curve response. So you need to reduce it slowly only.
Here after the initial reduction less than 200, we admitted her and continued with her regular medication. And we checked her BP from time to time, and her BP was coming down.
Okay. So over 24 hours we reduce 25 to 30%, then slowly you reduce the BP. Okay, that is enough. So which all drugs we can use this type of condition? One is labetalol. Okay.
Then if patient is in hypertensive pregnant patient, we can give MGSO for
That is during pregnancy
time.
magnesium sulfate. But this is postpartum time. Postpartum time, she is having hypertension during pregnancy. It has increased. Now postpartum period also, it is high. So any drug can be used. Now beta blocker you are used.
Then
What other drugs you can use?
AC inhibitors.
Before starting AC inhibitors, we have to be very careful. Other important drug is hydrolysine. So you give beta blocker and oral hydrolysine. Hydrolysine is available oral. IV was available. It is not available. So initially you gave labetalol, that has got beta and alpha activity. Now you can start labetalol also. AC inhibitors, ARB, they can be started. They are very good drug. What are the limitations for them?
In pregnancy, it can cause teratogenicity.
Pregnancy, we don't use AC or ARB.
Other than that, both can cause renal.
If there is already a pre-existing renal disease like creatinine 3 or 4 or renal artery stenosis, we should not use AC inhibitor or ARB. Otherwise, they are also very good drugs. Okay.
And then clonidine is another drug.
Clonidine can be given. Almost all drugs can be used in this type of condition. But here beta blocker is already started because it's hypertensive emergency. Hydrolysine can be added. Then already she is on calcium channel blocker like Nicardia. That can be continued. Okay, then.
That will, other than that, if a patient is having continuous BP, we can initially start with infusion of labetalol infusion or else nitroglycerin infusion can also be. NTG infusion can be done.
What is the common side effect of NTG? Common side effect is headache. It's a vasodilator agent. Any patient who is on NTG, you can ask. Most of the patients will have severe headache. That is only limitation. Otherwise, that is also safe drug in most of the conditions. So NTG also can be started. Then, what happened to this patient?
Patient initially her BP we reduce like from 230 reduce less than 200. Then we monitor the patient and her BP began to come down with her own medications. BD medication was there and BP began to reduce over the course of day and later on we discharged her.
Okay. Any other target organ dysfunction was there? Creatinine is elevated?
Creatinine was normal, sir.
But only hypertensive retinopathy was there?
That was there.
Okay. Echo was normal?
Echo was normal.
Urine protein was present?
Urine protein was 1+.
1+. So proteinuria is there, but other things are normal. If there is proteinuria and if there is creatinine is normal, what is the ideal drug to control the kidney disease? Here the patient is having SLE, high BP, proteinuria is there. What will be the best combination to control the renal damage in SLE? Now patient is already having proteinuria.
Clonidine.
That is AC inhibitor or ARB. Okay. So that can be started. If creatinine is normal, proteinuria is there, that AC inhibitor or ARB can control the proteinuria. Okay. Progression can be prevented. What is the evidence of SLE in this patient?
She was history was she was having some ANA was 3+ with history of alopecia.
Alopecia, ANA is positive, anti-DS DNA also positive. Okay. She is on Azoran and
HCQ.
That has to be continued. Okay. On discharge, what is the BP?
Her BP was 150, 160, hovering around 150, 160 over 90, 80. Okay.
So are you satisfied with that BP?
You want to be like 140 will be.
When the patient is already having a vasculitic problem, on discharge that BP may be sufficient, but long term you have to control the BP to a level to normal BP. Otherwise, patient develops progress to like renal disease. Okay. What happened to the potassium on follow-up?
Potassium was lab potassium came out to be 3.6 and.
Okay. What is the importance of potassium in controlling BP?
After controlling potassium, if the potassium is normal only, the BP.
What is the action of potassium on the blood vessels?
Vasoconstriction.
Potassium, if it is good, it produces vasodilatation. If potassium is low, that produces vasoconstriction. Let's say when potassium is low, BP increases. Okay. Any patient like this, if potassium is already low, before you start ACE or ARB, you have to make sure that potassium is normal, and you have to maintain the potassium little higher. Higher means not more than normal limit, but at least 3 point. This is only 3.5. 4 or 4.1 you have to keep. For that, you can advise the patient to take lot of lemon juice. Like instead of giving pot chlor that produces gastritis, lemon juice or fresh fruit juice, that will improve the potassium very fast. Because unless until you correct the potassium, BP will not be getting controlled. So that also should be taken care. Any pain is there on the patient, like post cesarean, that also pain also should be controlled. Okay. So what is this patient? This is a patient who is having SLE with high BP. The high BP may be due to SLE itself, renal involvement. So long-term follow-up is required. BP has to be tightly controlled. Proteinuria should not be progress to end-stage renal disease. We have to take care of all these things. Okay. Thank you.